So I already introduced myself. I'm the chair of the Department of Geriatric Medicine at JABSOM. I will be talking a little bit about just where the field of geriatrics is headed at a future session. There are a lot of alarming changes happening in geriatrics, particularly in having enough numbers to support the population. I'm also the academic medical director of geriatrics at the Queen's University Medical Group, and I'm the director of research at Kokini Medical Center as well. So I'm going to start with this very dramatic statement. Alzheimer's disease is a public health crisis. There's an estimated almost 7 million people now living with Alzheimer's or another form of dementia. It's the 6th leading cause of death across all ages, and 1 in 3 seniors will die with some form of dementia. Before I move on, I'm going to ask people to raise their hands if you have had somebody close to you, a family member or a friend, affected by dementia of any kind. Could you raise your hand, please? It's the majority. I'm actually surprised it's not every hand in the audience. It is such a common problem. I've been teaching dementia, taking care of patients with dementia, and doing research on dementia for decades now. Yet when my dad developed Alzheimer's disease, I felt so very helpless because there was so little that I could do for my own father, who passed away eventually. And honestly, his passing was so mixed. It was a blessing in some ways because he really didn't do very well. And yet, you have the sadness as well. So it is the reason why this is such a devastating illness is you have a series of multiple losses over a very long period of time. You're losing that person inch by inch almost, so I'll tell you some personal stories as I go along too. So before I start with the doom and gloom of dementia, I'm going to talk about the good news, healthy brain aging. First of all, what is it? This is what all of us wish for as we age. We want to have the ability to think, reason, remember, carry out our tasks, live a purposeful, independent life, keep social connectedness with our friends and family, and keep our own sense of identity. So this is sort of the ideal. However, with aging, we do see some changes, even with normal aging. Certain parts of the brain actually shrink. When they look at MRI scans done over a period of time, on the same person even, they can see that the hippocampus, which is the memory center, starts getting smaller and smaller gradually over age. And there's this slight decline in ability to learn new things, and particularly in retrieving information. Do you all have that sometimes where you're kind of like, you're trying to place something and it just takes a while to get it. You'll get it eventually, but it takes a while to get it. I've had patients who, they never went to college, not because they weren't smart, because they never had the opportunity. They grew up on a plantation. They had to go to work to support their siblings. And so that was it for them. After they retired, they've told me, now I'm going to fulfill my dream of taking college classes. They've come back to me and said, I can still do it, but it's not the same. Memorizing things is not as easy as it was when I was 18 or 20 years old. And we all see that difference, right? Whenever we have to learn new things, it just takes a little bit longer. There's also a difficulty in multitasking. Now, some people say the whole concept of multitasking at any age is stupid, that we should do one thing at a time rather than try and do multiple things at a time. But as we get older, it's harder to bounce back and forth between tasks. However, it's not all bad. There are improvements in things like vocabulary, problem solving, impulse control, judgment. All of those things get better with age, the things I call wisdom. So it's not that your brain is just getting worse and worse. Yes, the memory does get a little worse, but other areas improve as well. Now, we used to think if you were unlucky and it was in your fate to develop dementia, Too bad. It was just luck. Now we know that's really not the case. There are a lot of things we can do, lifestyle factors, even medical factors, that we can do throughout our lifespan to try and keep our brains as healthy as possible. So, Virginia, you'll be interested to see these are the pillars of the mini medical school, correct? Staying physically active, staying socially active, staying mentally active. All of those three you have done a little bit of today just by coming here. You had to walk from your car to come here. You had to walk to your car. You socialized. It was lovely to see everybody socializing during the break. You're mentally active because you're being forced to listen to people talk about various topics. The good nutrition, okay, sometimes we fall down on that, but these are the pillars of what we need to do to keep our brain healthy. In addition to that, in the last 10 years or so, we have found there's a huge heart-brain connection. So when we control risk factors for heart disease, it's also very good for the brain. I'll talk a little bit more about that as well. For physical activity, people often will say, I have arthritis or I have, other musculoskeletal conditions. I can't run, I can't jog. That's okay. I will show you some data from our own research that shows that even walking can be really good. So as Bennett said in the session before this, keep moving. The more you move, the better you will do, the better it is for your brain as well. There's a lot of research now being done to look at physical activity as an intervention to see, does it slow the progression of dementia? Does it even prevent the onset? To see what will happen. Social activity is huge. We found out, particularly during COVID, how very important social activity was and how very devastating the lack of social interaction was as well. Mental activity. There are a lot of claims out there about, buy this book and you will not get Alzheimer's, or play this puzzle and you will not get Alzheimer's. Please be careful of those claims. There's no one intervention that has been proven or disproven. What I say is pick something that you like. It could be reading. It could be playing music. It could be attending lectures. Could be doing puzzles, Sudoku, whatever it is. Pick a mental activity you like to do and just make sure that you keep doing it. For the nutrition, it's kind of controversial. I'm sure I'm going to be getting questions on this, but I'm going to tell you the only diet that has been sort of consistently shown among studies to be effective for prevention of particularly Alzheimer's disease is the Mediterranean diet, or different versions of the Mediterranean diet, which is actually very common sense. Lean proteins, less saturated fat, salts, sugars, more green leafy vegetables, very common sense kind of diet. And the Mediterranean diet has been found over and over again to be quite effective. So looking at the heart disease risk factors, I've listed them all here, but the top two are by far high blood pressure and diabetes. And the point is to control these factors throughout your lifespan, not to wait until old age. So I'll give you the example of high blood pressure. Most people develop high blood pressure in middle age. It's very rare that somebody develops it for the first time in old age. It can happen, but most of the time it's people develop in their 40s or 50s. It's very important to have lifelong control of your blood pressure. So it's not the geriatricians who are going to be doing this, right? It's going to be with your primary care physician. High blood pressure has no symptoms most of the time. So people figure, I'm feeling great. Why should I take this medication? Well, you're taking it as an investment to prevent complications of high blood pressure down the road. Good control of high blood pressure throughout your life is good for your brain just as much as it is good for your heart and your kidneys and other organs. So those two, high blood pressure and diabetes, we recommend lifelong good control. If somebody has had high blood pressure since they were 40, now they're 80, and now we try to reduce that blood pressure dramatically, it actually could have a paradoxical effect, and it could make memory problems worse and falls worse and other things. So really, these are lifelong control. High cholesterol, obesity, stopping smoking is a good idea at any age, and then again, staying physically active. So next, I'll move on to what is dementia. I'll start with some common myths about what it is not. The first thing is that memory loss is the same as senility or becoming senile, and it's an inevitable part of growing old. I looked up the word in the dictionary. Senile means old. If you're saying becoming senile is equal to dementia, you're saying every older person has dementia. My mom is 92 years old. Her memory is better than mine. I don't know what that says about me, but she's physically, her body is not keeping up, but her memory is fabulous and her attitude is fabulous. It is not inevitable. All of us know people in extreme old age who have a really good memory. It is definitely more common with aging to develop memory problems, but it's not inevitable. The second myth is that nothing can be done, so why bother to look? Unfortunately, a lot of physicians even feel this way. They ask us, do you have a cure? The answer is no, we definitely do not have a cure. So then they say, well, why bother to look? I hope by the end of this talk, I will convince you there are many reasons that it's important to find it early. And the third myth is most people don't want to know if they have dementia. When they've done studies on this, it's not true. When they've asked older people, if you did develop dementia, would you want to know? The majority of people said yes, they would. So I think all of these misconceptions contribute to why dementia is missed a lot of the time. What we are really seeing in dementia is the tip of the iceberg. There's a lot below the surface that's actually hidden. I'm hoping that over time that will come to light as well. So these are the facts. It is not normal aging. It actually represents several types of diseases. The other fact is it's common, it's underdiagnosed, it's a very expensive disease, and it's a fatal disease. People do die of dementia. And the other fact is patients with dementia should have a thorough evaluation by a physician who's expert at this condition. It could be your PCP. Some PCPs are pretty good at dealing with, I wouldn't say normal dementias, but I would say common dementias. Maybe they need to refer for the unusual ones, but the common ones they can handle. Some cannot. Geriatricians, this is our bread and butter. We live and breathe the dementia every day. And then sometimes neurologists are part of our care team too. For some of the very rare dementias, actually even we refer to the neurologists for that. So what is it? First is it's acquired deficits. So it doesn't include people who are born with intellectual challenges. People with mental retardation, that's not called dementia. These are people who were intellectually functioning normally and now have had a change in function. We see a deficit in memory, but not only memory. It has to be at least one other cognitive domain has to be affected. Things like your visuospatial ability, language ability, problem solving, at least one other thing, and memory. It has to be bad enough that it's affecting your social functioning with your family and friends, or if you're still working, it's actually affecting your job performance. You're not able to do your job as you used to be able to. And we need to have an absence of delirium. Delirium is something I want to actually add to the topic list for next year. I was thinking about that as I was preparing for this talk. Delirium is an acute confusional state. It happens over hours to days. It's most likely seen in the hospital. Have you all seen that? You're visiting an older person in the hospital. They're hospitalized for anything. It could be pneumonia, it could be a urinary tract infection, it could be a heart attack, and they're suddenly confused. It just happens suddenly. A lot of it is reversible. That's not dementia. We get consulted in the hospital as geriatricians sometimes. This person's confused. Do they have dementia? We cannot diagnose dementia in the hospital. We can say they probably have a delirium. Let's wait until they're stable. So if somebody has a delirium, you cannot make a diagnosis of dementia. The same is true for major psychiatric illnesses. If somebody is in the throes of a major depression, we have to treat the major depression and then see what's left after the treatment of the depression to see whether or not they have a dementia. In addition to dementia, there's this condition called MCI, or mild cognitive impairment. This is sort of like a pre-dementia. We see this in some people for months to a couple of years, in some people for many years prior to the onset of dementia. We see a subjective cognitive complaint. It could be from the patient, but most of the time it's actually not from the patient. It's usually from a proxy. A family member or a friend will notice that the person is having problems with their memory. The patient themselves, they actually think they're doing fine. But on testing, we see some deficits. They have normal social and occupational functioning. So they are interacting with their family and friends just fine. If they're working, they can manage working. But we're noticing on testing that their memory or other domains are not so good. This is sort of a pre-dementia, and these people with MCI have a high risk of converting to dementia, particularly to Alzheimer's disease. The conversion rate is about 12 to 15% per year. So in 5 years, about half of these patients will have a diagnosis of dementia. Why one half and not the other half? Nobody knows. That's a huge area of research right now. If we could figure out to halt people at this stage and not allow it to progress, it would save so much misery and so much cost as well to people. So how common is it? About 13% in those over the age of 65 and almost half in those over the age of 85. We see this geometric increase in the prevalence of the disease. After the age of 60, it doubles every 5 years. So I'm going to go to this next slide. Let me see if I can do the pointer. Okay, so this blue bar here, you can see how it's going up in a curved fashion. It's going up like this. It's not a straight line. It's a curved line going up very steeply. Same is true for the red line, which is dementia and MCI, or mild cognitive impairment. If you look at this 85 plus, look at this. This is about 1/3. And here, this is almost half of people will have significant memory problems after the age of 85. So a very, very common problem. Why is it so steep? Because people live with this disease for a very, very long time. There are some diseases where you get the disease and you pass away very quickly. Not with this. Most people with dementia live with it for years, sometimes even decades. So even though you live with it for a long time, it is a major cause of disability, and it's the primary reason for a person being put into a nursing home or a care home or some kind of institutional setting. In Hawaii in particular, I think about 80% of people in long-term care, not rehab now, but long-term care, are there because of dementia. And look at the cost. It's over $360 billion annually for direct care, and at least an equal amount for lost productivity, which is the families bearing the majority of the cost. So think about it. These patients need caregivers. And particularly in Hawaii, the family does their very best to keep them at home and to take care of themselves. But it does mean a lot of sacrifice. I've known a lot of people who've had to either quit their jobs or sort of take on an easier job or take on a part-time job because they are caregiving for their loved one. So next, let's move on to the subtypes of dementia. This slide is super important because I think there are a lot of misconceptions about what dementia is. Dementia is the umbrella diagnosis. Under dementia, all the different types, the most common type happens to be Alzheimer's disease. But there are many others. There's vascular dementia, which is related to strokes. There's Lewy body dementia. There's frontotemporal dementia, and many, many others that are not even on this slide. Alzheimer's is the most common by far, but I will show you some research from our own studies here that show the distribution is different in white populations and in Asian populations. So I'll show you that in the next couple of slides. So when we look at the dementia subtypes, this is the distribution in white populations. That big blue wedge is Alzheimer's disease. Depending on which study you look at, it's 60 to 80% of dementia is going to be Alzheimer's. Then there's this red wedge, vascular dementia. This is related to strokes. In Hawaii in particular, we find that people who have vascular dementia may not even have a history of strokes. In white populations, most stroke-related dementia is related to large strokes. So somebody is doing okay, they have a stroke, their memory drops, then they plateau. They have another stroke, memory drops, then they plateau. It's sort of like a stepwise progression. In Asian populations, we don't see many of these large strokes. We see a lot of tiny strokes, what we call subclinical strokes. The patient had no idea they had a stroke. We do a scan and we find little Swiss cheese dots, little strokes that happened. It happens gradually. When you ask the patient says, I never had a stroke. They're not weak in one leg or one arm. It is subclinical tiny strokes that accumulate and that cause the vascular dementia. Lewy body dementia is associated with these abnormal proteins. All of these have abnormal proteins, but has a special abnormal protein in the brain. But we find a lot of movement problems with these patients early on. So they will have slowness of movement. They may have hallucinations early on in the dementia, and they tend to progress faster than Alzheimer's disease does. It's a very distinct pattern that we see. And again, you have to go to somebody who's kind of expert in dementia to see the differences between them. Parkinson's disease over a long time can cause a dementia as well. So if you've had Parkinson's for many, many years, in the end stages, it's usually in the end stages, not in the early stages, but these are patients who've had a long history of Parkinson's and then develop a dementia syndrome. Frontotemporal dementias, I actually have not seen many through my career because they tend to start earlier. So they tend to be people who are younger, and so they usually don't come to geriatrics quite as much. These can be quite devastating because personality and behavior changes are very dramatic in these patients. Memory is actually preserved very early in the disease, so it can kind of fool people. But again, experts in the field can tell the difference between them. I want to tell a little bit about our research here at Kokini. So Kokini is the home of the Honolulu Heart Program and the Honolulu Asia Aging Study. The original study started in 1965 at Kokini Medical Center. So it actually predated the medical school. It's very rare to see one of these large studies in a community hospital, but Kokini was very far thinking even from then. They sponsored the study of 8,006, at that time, middle-aged Japanese American men, and it started out as a disease of heart disease and stroke. But as the men grew older, investigators at the NIH realized that this is a really good opportunity to study aging. So in 1991, the Honolulu Asia Aging Study was added to look at men ages in 71 to 93, and specifically to look at cognitive function, dementia, and also other things that get more common with aging, disability, depression, other things like that as well. So this cohort is now in the 60th year of follow-up. This is now the 60th year. It's the third longest running study in the United States. Out of that 8,006, there are 3 men who are still alive. The youngest is 105 years old. So this is really a study of extreme old aging. We've had over 100 centenarians. I think if we look at over 95, it was several hundred. And then when we look at people over 90, it was over 2,000. So it's a very, very long-lived population. And this is what we found. This is the prevalence rates of dementia. So I'm going to orient you a little to this slide. So this is age groups, 5-year age groups, starting with 71 to 74. This is the 85 plus. And this is just percentage on this axis. The blue bars are overall prevalence, and the red is dementia and MCI combined together. So if you remember those line graphs I showed you, the curve, very similar to this. And if you look at this oldest age group, again, about 1/3 with confirmed dementia and about almost half when you include the MCI. So very similar to the national statistics, right? But we were different when we looked at subtypes of dementia. So if you remember that pie chart that I showed you, where Alzheimer's was huge and vascular or stroke dementia was just a little wedge, right? 10 to 20%. Here we have blue is the Alzheimer component, and red is the vascular stroke component. And look at this. In this youngest age group, stroke-related dementia was actually more common than Alzheimer's. Now, after that, Alzheimer's overtakes and becomes number one, but the ratio is not like the 60 to 80% Alzheimer's and the 10 to 20% vascular. And in Hawaii, we find that with our Asian populations, we see more Alzheimer's than they do in other populations. But we also see a lot more vascular dementia than we do in white populations. A lot of our patients here have a mixed dementia, where they have some degree of stroke as well as the Alzheimer's disease. So let me move on then to Alzheimer's disease. It was first described by Dr. Alzheimer in 1906. He called it a pre-senile dementia. The original patient was a lady in her early 50s who developed a devastating dementia, progressed quite rapidly, had severe behavioral problems. She died a few years after he started taking care of her. And he actually took her to autopsy. He got her brain, and he described the plaques and tangles, which this day are the hallmark of Alzheimer's disease. So over 100 years ago, we knew what this was. There was very little research in this disease until the 1980s. Any guesses why? Why did it take the world so long to realize this is an important disease? Any guesses? Yes, that's absolutely correct. In 1900, life expectancy was about 45 to 50 at most. So most people didn't live old enough to develop Alzheimer's. As over the century, the population started aging, it became common. So it started out being a very rare disease to ended up being a very common disease. So we're behind because we didn't start research early enough, trying really hard to catch up now. It's the most common cause of dementia, about 2/3 in Western countries. Short-term memory, orientation, and problem solving are affected very early. Behavior problems are very common in Alzheimer's. In different studies, from 70 to up to 100% of patients with Alzheimer's will have some degree of behavioral problems. It's a very insidious onset. You can't tell when it began. In fact, if you talk to different family members, you'll get a different answer because it creeps up on you. If you're living with the person, actually, it's very hard to notice a difference because it's not a day-to-day difference. When my dad first started having symptoms, he lived in India, I lived here, so I used to see him once or twice a year. I noticed my brother and my mom had not noticed anything because they were seeing him on a daily basis. But it's relentlessly progressive. Most of the time, it's a very slow course. The duration from diagnosis to death can be from 2 years to 25 plus years. Some go very, very slowly, some go quicker. On average, it's about 8 to 10 years from diagnosis to death. This is Dr. Alzheimer, and this was that first patient, August Dieter, the lady who was seen by him, the very first described patient with Alzheimer's disease. So let me tell you what happens. There are some changes in neurochemicals in the brain. Now, neurochemicals are the sort of chemical messengers of brain, between brain cells. So this shows, between the nerve cells, there's these chemicals going back and forth, sending messages. Acetylcholine is the memory chemical, and acetylcholine is particularly low in Alzheimer's disease. Others are too, but particularly acetylcholine. There's also two abnormal proteins that are laid down. These are what we call beta amyloid plaques, right here. And these are what we call neurofibrillary tangles. These are abnormal proteins we don't see usually in the brain, but they're deposited in the brain in Alzheimer's disease. Again, we've known this for over 100 years. All of the treatments prior to the last 2 years or so have been focused on this, the chemicals. How do we get more acetylcholine back into the brain? What these two proteins do is they kill cells. Neurons are brain cells. The proteins are strangling brain cells and killing them. So if you look at this, this is an autopsy picture of a normal patient and an Alzheimer patient. You don't need a microscope. These plaques and tangles, you have to look at under the microscope. This, you can tell this brain has shrunk. This brain has lost nerve cells, right? The problem with the treatments prior to this, they were all focused on putting back the chemical, not on how do you save these brain cells from dying. So let's move on then to risk factors. I divide them into two, non-modifiable and modifiable. So far, we have still not found a cure for aging. So age is by far the strongest risk factor for Alzheimer's disease, and almost equally strong as a low education level. These two factors are consistent in every country, in men and women, in every ethnic group. Age and education are the two strongest risk factors for Alzheimer's disease. Traumatic brain injury is a little controversial. Some studies have found it, some have not. In general, I do not recommend getting your head repeatedly bashed in. I don't understand certain sports. My husband loves to watch some of these things, and I'm like, don't watch this, it should be illegal. But the whole point of, for example, boxing is to knock the other person out. The point of the sport is to give the other person a concussion bad enough that they will pass out. That's not good for the brain, obviously. A lot of attention is now coming to this with the NFL, the National Football League. They've been noticing that with these young, healthy men in their 20s and 30s with repeated concussions, when they're doing these neuropsychological tests on them, they're testing like they have Alzheimer's disease very early. So long-term effects are not good. I don't recommend it at all. I have a whole slide on genetics, so I'll go into that in the next one. We talked a little bit about the modifiable risk factors, cardiovascular risk factors, particularly high blood pressure and diabetes, dietary factors. Heavy alcohol intake is really bad for the brain as well. Now, actually, the Surgeon General actually came out saying most alcohol should be cut out because they're finding a link with cancers, etc. Low levels of alcohol probably don't cause dementia, but heavy alcohol intake, there is something called an alcoholic dementia, which can be irreversible even when somebody stops drinking. Depression is interesting. We know that if somebody has a major depression, that causes cognitive problems in old age. If we treat the depression, the memory actually gets better. However, 5 years from then, half of those patients have a diagnosis of Alzheimer's disease. So we don't think depression causes it. We think it's an early marker for it, that these patients are showing these early depressive symptoms. That's then sort of foretelling that they're going to be getting dementia a few years later. Chronic inflammation has been implicated. Sleep apnea has been implicated. I think getting good, healthy sleep is very important for the brain as well. And hearing impairment is super important. So we used to see that people who had hearing impairment had a higher risk of dementia. What we didn't know is if we correct the hearing impairment, will it reduce that risk? Now, early studies are showing probably it will. So it's very important for people who have hearing impairment to get their hearing corrected early for many reasons, partly their brain and then partly quality of life and socialization as well. I can answer in the questions, yes. So when we look at genetic testing for Alzheimer's, we find two different types of Alzheimer's. I'll start with the one on the right, the early onset Alzheimer's. This is a very heavily genetic Alzheimer's. It's very rare though. Less than 5% of it is this early onset. These are people who develop the disease in their 30s, 40s, and 50s. This is the type that movies are made out of because it's very dramatic, right? These are young people, they're in their careers and they have young children, so it's very dramatic when they get it. This type is very familiar. We've so far found 3 autosomal dominant genes. Autosomal dominant means if you have the gene, 100% you will develop the disease. So you can imagine how devastating this is. For these types of patients, I do recommend genetic testing and genetic counseling for actually the whole family. For the late onset or sporadic Alzheimer's, family history is a slight risk factor, but part of it is just longevity. Longevity tends to run in families. If your mom and dad live to extreme old age, your brothers and sisters live to extreme old age, you are more likely to live to extreme old age as well. The longer you live, the older you are, the more likely you have Alzheimer's in your family because it's an age-related condition. So part of it is just you have more longevity in your family. There's one gene that has been found to be risk factor. That's the apolipoprotein E4 gene. It increases the likelihood, but it doesn't guarantee it. So I don't recommend testing routinely for this. I will tell you though later on when I'm talking about treatments, with one of our new treatments, I do recommend it if you're being considered for that treatment, and I'll tell you why later. What about the protective factors? Walking. Again, this is from our Kokini Honolulu Asia aging study. We looked at these older Japanese men, and on this axis here, I have distance walked in miles per day, and this is the relative risk. So this was the baseline group. This is people who walked over 2 miles a day. This is their baseline risk. And then if you walk less, your risk got higher and higher. And look at this, the people who walk less than a quarter mile a day, the risk was almost double for developing a new dementia 8 years later. So walking clearly helps protect you from developing dementia. Again, as Bennett says, keep moving. That's super, super important. We found something similar with social engagement. Again, we looked at people who were free of dementia and we divided them into 4 groups of social engagement from high all the way down to low. And look, the risk as you go with less and less social engagement, your risk of dementia goes up and up, more than double in the low social engagement group. So it's really, really important that even after retirement, don't just sit there and stare at the TV all day or watch YouTube on your phone all day. Go out with your friends, family, do things, keep socially engaged. Next, I'll talk about why early detection is so important. We talked about this, how even some of the doctors are saying, why bother? Well, first one is some causes of dementia are actually reversible, but they're only reversible if you find them early. So you need to find them quickly so that you can take care of them. That's one. The other one is improving treatment of underlying conditions. I think this is even more important. For example, let's say somebody with early dementia goes to the doctor's office. They go alone. The doctor's talking to them about their high blood pressure and their asthma. And they're telling them, take these medications, do this exercise, do this with your diet. The patient is smiling and nodding. Are they remembering anything? Probably not. They are socially appropriate. Hey, doc, how you doing? I'm fine. They look completely normal, but they're not going to remember anything. How is their high blood pressure and asthma going to be taken care of? Not well, right? If we knew they had dementia, I would say a family member should go in with them, or at the very least, they should have written instructions or a lot of those things put together. Not finding dementia early also reduces ineffective and expensive crisis-driven care. These are patients who miss appointments, miss medications, or overdose on medications accidentally. They forgot they took it. They take it over and over again. They end up in the ER. They end up in the hospital. Patient and family education. Advanced directives for healthcare are super important. Does everyone in this room have an advanced healthcare directive? Please see your hands. Okay. I notice our staff don't. Now they are young, but I'm going to lobby them. I had my first advanced directive when I was in my 20s, because you never know when things might happen. It's really a blessing to your family to have these in advance. Okay, I'm going to work on the staff next. And then financial planning. I told you this is an expensive disease. You need to plan for your future. Safety issues. I have a whole slide on safety I will show you. And then connecting people to available community resources is important as well. Looking at non-recognition, this was again from our Kokini study. These were people who had no dementia, and we studied them with our research criteria. They had no dementia. These people had MCI, and these people had definite dementia. We asked the caregivers, does Mr. X have a problem with his memory or thinking? Focus on the red. These people said no problem. Even among people who met research criteria for dementia, 20% said no problem. Half in the MCI group. It is very easy to miss. This was even more alarming. We asked, have they had an evaluation for their memory problems? Again, look at the red, which says, yes, they had an evaluation. Among the dementias, only 40% were evaluated. Among the MCIs, less than 5%. We are not doing a good job. This was a study done by one of my previous fellows on undiagnosed dementia in primary care. He looked at a group practice, and he actually examined those patients and then saw whether that was documented in the chart. And he found among all patients, 2/3 of dementia was missed by the doctor. Among the mild dementias, 90% were missed. Moderate, half were missed. Okay, they didn't miss any of the severe dementias. Should we be proud of that? Anybody could do that even by just looking, right? So even doctors not doing a very good job with this. The symptoms, we see memory loss. Usually short-term memory loss is the most noticeable, later long-term as well. Disorientation to date and to place. Getting lost is common. Now, I don't mean when you're visiting another city and you're driving around getting lost. Everybody does that. Even with Google Maps, we all do that, right? I'm talking about having a hard time getting home from the grocery store in the home you've lived in for 40 years. You just, even familiar places, you get lost. Difficulty with naming and understanding, lack of insight. They don't realize they have a problem. The most common memory complaint in these patients is, Doc, my memory is great. They don't realize it. They may have depressive symptoms. They may have personality change. Wandering can be really dangerous. And in late stages, being socially inappropriate and having poor judgment as well. This one I won't focus on too much, but I do want to say the hippocampus is kind of deep inside the temporal lobe. So you can see memory, mood, speech, and language are affected very early in Alzheimer's. Also, frontal lobe, personality, behavior, planning, motivation. Later on, sensory and motor functions, later on, visual processing. So these two, much earlier in Alzheimer's disease. I'm going to skip over this and move straight to treatment because Chang told me we're running out of time. So these are the 3 stages of Alzheimer's. There's a very, very long pre-symptomatic stage. We have no idea anything's happening. The plaques and tangles are being deposited in our brains during that time, but we have no clue. Okay? Then there's a prodromal stage, which is the MCI, where on testing you're not doing great, but you're still functioning. And then this is the dementia phase where now even your functioning is impaired. So if you look at these 2, this is cognitive performance from normal, little bit bad here, but getting worse. Function remaining normal all the way through here and then getting worse after. So what we really want to do is we want to catch people at this stage or latest at this stage to avoid going into the dementia stage, right? We want prevention as much as we can for the whole population. So all those things I talked about, early treatment of cardiovascular risk factors, exercise, socialization, good nutrition, all through our lives. Then early recognition of people at risk and then early diagnosis and treatment if you do have it. These are the FDA-approved treatments for Alzheimer's that we've had for many years. So these drugs, the cholinesterase inhibitors, there are 3 of them, and this one, the NMDA receptor antagonist or memantine, these have been around for many years now. At best, you can have temporary stabilization or slowed decline. It's definitely not a cure. All they do is replace those chemicals in the brain that are lacking. They don't do anything for the neurodegeneration or the loss of the brain cells. So, I mean, I was enthusiastic when they first came out, and I've quickly become pretty disillusioned. Do we offer them? Yes, I still would offer them, but knowing that this is not going to be a permanent cure. All they do is fix this, and they don't take care of this brain cells die. What we really need is treatments that focus on how do we get rid of these plaques and tangles that are strangling these brain cells. We do have some treatments now for the beta amyloid plaques. We don't yet for the tangles. That is in study yet, and I know there are some clinical trials being done, but nothing yet in the pipeline. But for the plaques, we do have some, so I do want to cover that. These are beta amyloid antibodies. The first one, aducanumab or Aduhelm, was actually taken off the market last year, so I'm not even going to mention it. The second one is called lecanemab or Leqembi. This was fully approved by the FDA in July of 2023. They did show clinical benefit in very early Alzheimer's disease or MCI, but the magnitude of this benefit is not sure. And how long this benefit is going to last, nobody knows yet. These studies are too young. They haven't had enough follow-up to know long-term what are they going to do. The other complicating factor is the expense. The drug itself costs $26,000 and $500 per year, plus all the other additional costs. I finally got an answer to the question I've been asking for a long time about what is the total cost of this drug over a year? And I was told it's somewhere between $85,000 and $95,000 for the drug with the administration, because you need an IV infusion every 2 weeks. You also need a lot of pre-testing and then MRIs at regular intervals because there's a safety concern. So the first thing is diagnosis. You need to get a very definitive diagnosis of Alzheimer's disease. We can only do that by amyloid PET scan. The state of Hawaii does not have an amyloid PET scanner yet. So to get this, you'd have to go to the mainland. Now, Queens is getting it. Last I was told was maybe August or September of this year. But it's not here yet because the time keeps shifting, you know. It's not as easy as I thought it would be to get this. So in not having an amyloid PET, you need a lumbar puncture, spinal tap. That has its own, risks. I mean, it's a pretty safe procedure. I shouldn't say it's super risky, but It's not the most comfortable thing. You have to get a needle put into your spinal cord and get the fluid from there. Then it has to be tested. The biggest concern I have with these drugs is the side effects. They cause what we call ARIA. ARIA stands for amyloid-related imaging abnormalities. In simple words, it's brain edema or swelling and brain bleeding. And we see this in a pretty significant number of people. It's up to 20% of people on these medications will have these side effects. Many of them will be mild, but still, it's something significant that you're causing something to happen to this person. So we have to do really good informed consent to make sure that people are willing to take this risk. So let me show you the data from this original lecanemab study. They looked at the mean change from baseline. So let me explain this graph. This axis here is time. So it's from 0 months to 18 months. You can see already, this is a disease that lasts years. Many of these clinical trials are 1 to maybe 3 years at most. So long-term, what's going to happen? Nobody really knows yet. This is the placebo group here. So both are getting worse. The lecanemab group is also getting worse. This is the placebo group is also getting worse. But the placebo group is getting worse faster than the treatment group. So they did find that there was a statistically significant improvement between the two groups. So both get worse over time, but lecanemab seemed to slow the worsening. This next slide is, there was a 27% reduction in decline, sorry. This slide is really important. So particularly this graph. This is amyloid burden on PET. So remember I told you that beta amyloid is that abnormal protein in the brain. When they did PET scans after the drug, look at this, the placebo, the PET scan looks the same. Obviously, the amyloid is still there. Look at lecanemab. They have a huge decrease in the amyloid. So that abnormal protein is definitely being cleared from the brain by this drug. What we don't know is, why aren't these graphs, which is worsening of function and of cognitive status, not as dramatic? If these graphs were really like this, I would be like, wow, this is incredible. But they're not. They're showing both groups are getting worse, just the treatment group is getting worse a little slower than the placebo group. So if you ask me my final conclusion on this drug, do I recommend it or not? The answer is I don't know. I think time will tell. I think it's an individual decision. It's such a devastating disease that I can understand some people saying, I'm willing to take the risk if it might slow the disease. But we don't know yet whether it truly will or not, long term. Some safety issues in dementia. Medication is a big one. Taking too much, taking too little. Over-the-counter medications are a huge issue. How many of you have heard of Benadryl? Everybody almost. And Benadryl, the chemical that's in Benadryl is in many of those Tylenol PM, Dayquil PM, NyQuil PM, all of those, they have that same ingredient in there. That is an anticholinergic drug. It reduces the level of acetylcholine. Alzheimer patients already have a low level of acetylcholine. Now you give them an anticholinergic drug, it doesn't make them sleepy, it makes them crazy. So you have to be very careful with patients with Alzheimer's to not give them the wrong drugs. So I always tell people, please ask the doctors before giving them anything. Wandering, having a medical alert bracelet can be really important. The Alzheimer's Association locally was very successful in passing the Silver Alert Bill last year in Hawaii. So you don't have to wait to report a missing person who has dementia. The search starts immediately, just like an Amber Alert for children. And the time is important, right? Because when somebody with Alzheimer's is lost, you don't want to be waiting a day or 2 days to start the search. Leaving the stove on. leaving the water running, we know that those have been sources of problems as well. Driving, that's a whole topic in itself. Just having a diagnosis of dementia doesn't necessarily mean you stop driving. On the other hand, I always tell people, I'd rather I stop you a little too early than a little too late. We don't want this. Or, we had that in Hawaii Kai a few years ago where somebody drove right into a restaurant, actually backed out and drove back into the restaurant. Fortunately, nobody got killed. But, those kinds of things do happen, so it's really important. These patients are at risk for elder abuse and neglect, particularly for financial abuse. One of my colleagues wrote a really cool paper in the Hawaii Medical Journal many years ago, Excessive Sweepstakes Participation. He had a case series of about a dozen patients who lost lots of money, basically being scammed. So yeah, always be careful. So again, early diagnosis, family will keep out the watch and hopefully prevent these things from happening. So for summary of treatment, early diagnosis is the key. Treat the cause, treat complications, provide a safe and stable environment. Family education is critical and caregiver support is critical. Being a caregiver is the hardest thing, particularly for patients with dementia. So we need to support our caregivers. Interdisciplinary team approaches, community resources. By the way, in geriatrics, AA is never Alcoholics Anonymous. It's always Alzheimer's Association, just to let you know. And the Executive Office on Aging for the state, and then planning for future financial and legal issues. Our goals of care are very different for somebody with dementia. It's not necessarily keeping them alive longer, but improving the quality of their life and maintaining their function as long as possible. Avoiding social isolation. I've had patients ask me, we're having a family picnic this weekend. Should we take dad? My answer to that is, does dad enjoy it? They go, yeah, he enjoys it, but he never remembers. And what I say to them is, give him a good day. Give him lots of good days. Give him as many good days as you can. That's what happens with patients with dementia. They can have good days and bad days. Let's try and improve those good days. The last time I saw my dad was about a year before he died. He had had a hip fracture and he was in the hospital and he was unrecognizable to me. He was so confused. And then one day my husband and we went there, especially because he had his hip fracture. We walked into the room in the morning and my dad was sitting at the edge of this bed. He had a twinkle in his eye. He was teasing me like he used to tease me. My dad was back. Why suddenly that day, I have no idea. But I turned to my husband and I said, I'm not leaving the hospital today. I'm here all day today. And he had a good day that whole day. The next day, it was back to normal, back to what he was, I took advantage of that good day and I'm so happy I had that because I have the memory of that. So give our patients with Alzheimer's good days. And then care for the caregiver. Remember that they need care too. They need respite. If you know somebody who is a caregiver, volunteer, take them out, take them food, take them to lunch, sit with their loved ones so that they can go out or they can take a nap. Sometimes that's all they need, okay? Just a shout out to Aloha, a chapter of the Alzheimer's Association. We work with them a lot. They offer lots of wonderful programs. If you do know somebody who's suffering from any type of dementia, please go ahead and give them a call, go visit them. I'll stop here and see if there are any questions. Yes.
You mentioned the anticholinergic, like Advil PMs. If you are occasionally taking those before you have any of these diagnoses, is that making your risk factor go up?
Yeah, until a few years ago, I would have said no. But in the last few years, there have been some studies that have shown that long-term use of anticholinergic medications could have effects on the brain long-term too. So it's only been in the last, I would say, maybe 4 or 5 years that those have been coming out. So I would say if you don't need those, I'm a minimalist for drugs anyway. I really feel the less the better for the most part. I'm not saying stop all your medications, please. Don't do that. Talk to your doctors about it. But in general, in geriatrics, we de-prescribe a lot. And guess what? Patients actually do better. Yeah.
I have
Yes.
a question about the symptoms of Alzheimer's. Two in particular is the decline in short-term memory and paranoia
Yes.
that I've been dealing with.
Yes.
So the short-term memory, I understand, they can't remember, what happened today, an hour ago and stuff like that. But how long is short-term? That is, I can't remember things I did last month,
Yeah.
and stuff like that. So
Right.
I'm just wondering where's the difference between short-term memory and long-term memory, and how concerned should I be? I'm
Yes.
concerned my friend doesn't remember what happened today
Yeah.
and yesterday, missing appointments and all that kind of stuff.
Yeah. So I think it depends a lot on functioning. So if you are missing appointments on a regular basis, I mean, everybody messes up once in a while, but if it's on a regular basis, I would say that's a problem. In general, people with dementia don't remember what they had for breakfast an hour ago, but they'll remember in detail what happened 50 years ago.
Right.
So actually, that's what fools people into thinking mom can't have dementia because she remembers in detail my wedding from 50 years ago, but she doesn't remember what happened half an hour ago, or even a conversation. Within the course of like a 10-minute conversation, if the same thing is repeated 5 times, that person probably has a really bad short-term memory.
So it's okay if I don't remember what I did last month.
Yeah. I'm not sure I remember what I did last month
Okay.
either.
The second one is paranoia, because that just occurred last night.
Yeah.
And-
Paranoia in general, that's so disturbing. I'll tell you honestly, with Alzheimer's, the most disturbing part for the families is the behavioral problems. And paranoia is common. I cannot tell you how, and there are certain common things that we see. So one is the person who's taking care of them the most. So often it's one child who's doing the caregiving, or the spouse who's doing the caregiving. And then when the other siblings come, they say, they're not feeding me, they're stealing my things, etc. It is so hurtful. I've had spouses, talk about their spouse cheating. And the spouse comes to me and say, we've been married for 40 years. I've never cheated, and you don't need to explain to me. This is part of the disease process. That is what is so devastating to families, to be honest. The good news is, well, I don't know if there's good news, but it gets better over time. So as the dementia progresses, the peak of behavioral problems is at the moderate stage. So in early stage, you see a little bit of behavior problems. It gets worse with moderate stage. It gets better with late stage. It's almost like you become too demented to be agitated. I know that's a terrible thing to say, but at least the behavior gets better, and that is very disturbing to people.
Paranoia then is the middle stage usually, because it just came on last night. I mean,
yeah, I can't predict because everybody's going to be different. But yes, if you start seeing it, you may start seeing it more and more. I can tell you some simple tricks can really help for people living with somebody with dementia. For example, one of the things that drives people crazy is, the spouse is asking constantly, where's the bathroom? They've lived in that same house for years. So putting a sign on the bathroom, or maybe even a photograph of a toilet, I know that's not the most aesthetically pleasing thing, but that will prevent that person from constantly asking, where do I go? So they'll see that, and that will be a cue for them. I've had a patient where the spouse constantly wanted to go home. And that's a common delusion that they have. And they're in their home, and they say, now take me home. And the spouse is arguing with them, we are home. And then it gets into a huge argument and fight. Instead of saying that you can never argue away a delusion. So instead of doing that, I had a caregiver who they'd say, fine, let's go home. They'd put him in the car, drive him around the block a few times, come home, and they'd be perfectly fine. So being creative like that can help. Arguing with delusions never works. The paranoia is very difficult. It is very difficult to deal with. In very extreme stages, we do use medications to deal with them, but again, we try and minimize them as much as we can.
Find that using the same tactics I use with teaching preschool kids works.
Distraction can
Distraction,
help.
right?
A lot of things can help. I would say try those first. Meds, last resort.
Thank you.
Oh, yeah, this is for all of us. You say it's important to detect early,
Yes.
but then you mention a test when you have it already. What should our physicians
Yeah.
be doing for us already, even though we come in and I'm perfectly fine? What should she or he look in my eyes and say, I want to ask you?
I think that every person, actually, maybe even starting at 60, at the very latest at 65, should have an annual screening. I'm going to tell you, though, the US Preventive Services Task Force does not recommend it yet because they said there's not enough evidence to show that it'll change anything. My point is, they're right. If we had a cure for Alzheimer's, trust me, everybody would be screening if we developed a cure at some point. So someday, maybe. Even if you don't have a cure, I told you all the reasons for early diagnosis. I truly believe in those. And I truly believe that you can do so much good, even without the cure. You can do so much good for the patient and the family by finding things early that I recommend it. I teach it to our trainees. I tell them because normally I'm telling them, let's go by what the evidence says. Let's go by what the guidelines say. This one, I'm telling them, I'm telling you to not go by the guidelines. I'm telling you to do a little more because I believe it's very important. And I think it's important to get a baseline because everybody is different. So some people do really poorly on those tests just because they have a very low education level. They're not demented. They just don't do well, at numbers and at language and whatever. So having a baseline and looking at change, to me, is very critical.
Yeah, I've read that, when they do autopsies on people that don't have Alzheimer's, they often will have as much the beta amyloid plaques as those that do. And so, I've seen some people questioning whether those really are the cause rather than a symptom.
That's a very, very good question. The dementia community is kind of divided on this. There are a lot of people who believe that the amyloid plaques are only a very small part of the problem, and that the tangles or the hyperphosphorylated tau, that's the other abnormal protein that lays down, that is the more important factor. We don't know. There's a lot we don't know in this disease, unfortunately. About maybe 10, 15 years ago, the NIH finally put Alzheimer's as a priority area. And now any grants that go in with dementia in them have a higher chance of being funded than others. So people are being drawn to the field, partly because it's just easier to get a grant in dementia research than it is in other types of research. I don't care why they're in it. I'm glad there are more people coming into it. And so I hope that the pace of research will kind of keep increasing so that we find some of these answers. You're absolutely right. Amyloid is not the only thing. The other thing that we find is there's a link with Down syndrome. So for example, children with Down syndrome who grow into adulthood, when they've done autopsies of Down's adults who've maybe die in their 40s, 100% of them have plaques and tangles in their brain. Not all of them have a clinical dementia syndrome, though. They do have a higher rate of developing clinical dementia than the general population, but they don't all have it. So why do some people have those proteins but not have clinical symptoms, and why do others do? Those are all things I would love to have the answers to.
I often hear the statement that people die with dementia, not from dementia. So what is the situation there?
Yeah. So when we look at cause of death, it can be tricky. So you could have somebody who has maybe an early Alzheimer's disease and then has a heart attack and dies of the heart attack. In that case, Alzheimer's is sort of an incidental thing. People who are in end-stage dementia, most of the time they're actually dying because of the dementia. So late stage Alzheimer's, you have problems with your muscles. That includes the muscles of breathing. That includes the muscles of swallowing. So I would say one of the very common, final common pathways to death is pneumonia because you're aspirating. So the cause of death is not, the immediate cause of death is pneumonia, but the underlying cause is the Alzheimer's, the stroke, the Parkinson's disease, whatever it was that caused them not to be able to swallow. So no, again, I think we're trying to do more education with physicians because we are not taught how to complete death certificates. I was never taught. My training was the first time I had a death as an intern in Michigan. My senior resident took me aside and said, let me tell you how to do this. Spend 1 minute on it. And I was on my own after that. As I got into research, I realized how terrible a method of teaching that was. So now our fellows get a 2-hour seminar on how to do a death certificate properly and what it means. But in general, physicians don't get taught this very well. So death certificate data I always find a little suspect because it's only as good as what's put into it, you know. Now more and more people are finally putting in dementia as the cause of death. It should be. It is the underlying cause of death. Yeah.
I've had a couple of older friends that died of dementia, Alzheimer's in particular.
Mhm.
A couple of them died, they were happy right up to the end, smiling.
Yeah.
Some of them were just absolutely terrible.
Yes.
Is there anything that can be done to lead you down the happy path early on, or is that just the way things are?
You know, I wish I knew that. My dad went down the unhappy path. He went down fighting and screaming. So I've seen those, you know, the quiet dementias that are just happy and, you know, no problems. I wish everybody could have that, but no. So, yeah. Yes.
Diagnosis is important. That's what it sounds like. But I know a couple
Mhm.
who are on a wait list to get into a senior living facility. And there's a concern about being diagnosed with some type of dementia because that'll be part of your medical record, which supposedly places like that can ask for and might preclude them from being accepted into that facility. Can you comment on that, please?
Yeah, I don't know that they would be allowed to not take you for that reason, but I will actually ask that question because I know people at all of the assisted livings in town. So I will ask. That should not be possible to do. It should not be. But yeah, let me ask and I'll let you know. Yes, yes. Okay. Right, right. So the question was, some of these places have a memory care unit. So that is a big struggle with, I know this because I work with some of these assisted living facilities. Sometimes the people there are staying in their own homes way past safety because they're refusing to go or their families refusing to put them. And even in the skilled nursing facility, they're refusing to go. Again, it becomes a safety issue. So the staff are kind of pushing, but the person doesn't want to go. I think part of it is psychological. They kind of see it as this is the end of the line. And I get that, but on the other hand, if you're in an unsafe place, that's another issue too. So I would encourage people to listen to their health professionals. Yeah, yes. Oh, sorry. Do we have a mic? Sorry. Wait, sorry, just wait 1 second. We get your mic. Yeah.
I think this is the difference between getting accepted into the facility and being covered when you need the help when you move to the long-term care. You can get accepted, this is my understanding, you can get accepted, let's use Kahalanui as an example. You can get accepted into Kahalanui independent living because you are paying the full price. But when you need assisted living, if you don't pass the qualifications, you will be transferred, but it will not be covered because you did not meet the physical requirements. But this is, I'm sure there are some people here who are either at Kahalanui or are waiting for it, but that's my understanding to the gal. I believe you can get accepted into independent living, but everybody goes there with the hope that when you need further care, you won't have to pay the going rate. So there's a distinction getting accepted for independent living and already needing assisted living help because you're already there. You know what I'm saying is you need to pass a certain, isn't there anyone here who's at Kahalanui?
Anne was suggesting that maybe acceptance might be an issue, right? So I'll check with them on that. Let me just ask the source directly. Okay. Any more? Yeah. Oh, Mike.
I'd like to make a comment.
Out. You want this? Yeah.
Test one. Can you hear me now? I'd like to make a comment about caregiving. That's very important. Of course, education in general is important. I caregived for my mom for 18 years. She was diagnosed at 80 and she passed on at 98. And it was such a journey. But I'd like to recommend a support group. I tell people, I've never been to Alcoholics Anonymous, but like going to Alcoholics Anonymous, Project Dana, DANA, is locally established. I think, was it 36 years ago? By two local women. And they meet on the second and third Wednesdays of every month. And it was a lifesaver. I belonged to Project Dana for over 20 years. We go now as mentors because you can be in a family of care of siblings, and unless if you're doing the caregiving, they don't get it. It can be such a lonely journey. And you hear stories from other caregivers, and yes, they discuss all kinds of situations, but you know what? A lot of the situations overlap. And what I think is very important, people who did have the experience speak up, and man, they're right.
Yeah,
So
you're
it's not only
absolutely
the
right.
theory.
You're absolutely
It's the
right. We
practice.
had last year, caregiving was actually one of our topics, and the video is on our website. So please, anybody who wasn't there last year, please go ahead and check it out. And Alzheimer's Association also has support groups, by the way.
Oh.
Some are in person and some are online, even available for people who cannot get out. So yes, please do check out support groups. I think they are extremely helpful. Okay, thank you. Thank you all so much. I'm sorry we went a little over.